Good afternoon. I'm Dr. Duke Majan, CEO and founder at Duke Spine Institute. It is November 7, 2024. It is the afternoon. This is our last patient of the day. She has back pain, 2 herniated discs, 4-5-5-1. We are going to get into these discs. Are you ready?
Yeah.
And we're going to repair them. First, I need to make sure we have a good entry point. Shot. Don't move, you're doing good, Sean. That's not too bad, actually. I think we're going to be okay. Num num.
A little more medicine here. You're doing fine.
Everything's good. You're doing great.
Little needle stick here.
So our patients are not intubated with this surgery. They're under just propofol sedation. But in the beginning, I need their help. So I kind of keep them awake just enough to help make sure we're going in the right place. We are navigating to the disc shot. And these discs, remember, are right next to the nerves. So, shot, we need to make sure that we're able to get there without damaging any nerves. Don't move, you're doing good. Just lay still. Shot. All right. Now she's traveling here from Missouri. From Missouri, right? She said, yep. All right, hang in there, Sean. You're doing awesome, Sean. Getting down to that disc is tough. All right, give me an AP view. Let's see where we are. If you have questions, feel free to ask them. While we're trying to get into the bottom disc, let's show the audience why discs cause back pain, but also there are 30 different causes of back pain that are common. Let's show our audience those 30 causes.
Copy that.
I'm Dr. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The 4th most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Majin. Thanks for joining us. Welcome back. You can see from our video that
Don't move. You're doing great. Putting a little
there are 30 common causes of back pain, and the disc is the most common. Shot? And that's why we're here. We're here to fix her 2 discs that are causing her pain. Lay still, Shot. You're doing great. Lay still, though. Can't have you moving around. Shot. Uh-huh. Moving around is not helping. Shot. Are there any questions?
At this moment, no current questions.
Shot.
So
Lay still, AP.
in the meantime, why don't we show the audience of how a herniation causes back pain?
I think it's a great idea, Henry. So many good ideas.
I learned from the best.
Are you doing okay?
Disc injuries start with an annular tear, damaged nucleus. Pulposis herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
All right, Henry. Let's show the audience, since we've done a good job of showing them how a disc causes back pain, maybe you can show them how we fix the back pain caused by a disc.
Of course.
Disc injuries are a common cause of chronic back pain. The inflamed annular tear causes back pain. A 1/4-inch sized skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
Welcome back. You can see how laser endoscopically to get rid of back pain. Right now we're going to confirm the source of her pain. She's had back pain for 7 years, 7 long years. She traveled all the way from Missouri to come here. All right. All right, are you having any pain right now? All right. How bad is that on a scale of 1 to 10?
Give us a number.
What's the highest? Hell. That's 10 out of 10. Is that where you get your back pain? All right. We're going to get rid of that when you wake up, you'll be gone. She called it hell. H-E-L-L. All right. So L4-5 was living hell for her. That's the first time I've heard that in 18 and a half years. Oh, yeah. I mean, I've heard of bad, but hell. She's right, though. Living hell. It's torture. Is it better now? All right. How bad is that on a scale of 1 to 10? Another hell. So is that where you get your pain? All right, sweetheart. That pain's going to be gone when you wake up. Gone for good. You're welcome. All right. Go to sleep. Sweet dreams. I want you to count out loud from 1 to 100 so I can hear you out loud. So, folks, this is the best news. We just tested the 2 discs that I thought were causing her back pain, and indeed they are. You can see I injected her. I did not tell her when I was going to inject her. She had no idea. And she suddenly tensed up, her back arched. She said, "Oh my God." And I said, "Is that your pain you always get?" She said, "Yes." So we call that concordant. She has concordant pain. We're going to get started. We're going to go down to this disc and we're going to fix both of these discs with the laser. 7 years of back pain. We're going to get rid of it right now. You're going to get rid of that pain. Count out loud for me so I can hear you. All right, num num. Any questions, ask. Type them up. I'll do my best to answer them.
Yes.
But she is from Missouri. And lovely lady. She's here with her husband. I just talked to her daughter a little while ago in pre-op. And her daughter, I think, is in healthcare as well. Sean? You're doing great. All right. You're doing fine. Everything's okay. So you can see the tip of the dilator is down there by 5'1". Let me know, Sean. Let me know when I can proceed. Yep, take your time. Take your time. She also has facet joint pain. We're going to be fixing her facets with the Duke plasma rhizotomy next, after we're done with the disc. Sorry. So, Henry, why don't you show the audience how facets can cause back pain?
Of course.
Let me know when I can proceed. All right, welcome back. And you can see from our video that facet pain is also due to inflammation. Same as disc pain, but facet pain is due to inflammation in the facet joints. And she has both disc pain and facet pain. So we're going to be fixing both today. All right, I think we're in. Let's pull back a little shot. It looks good, huh? The good news is she's young. She's here early in the disease process. Now, if you get to these discs early enough, then you can actually preserve them and keep their height, keep their natural shape, keep their natural form, and they become painless once you clean up the tear. The procedure to clean the tear is called the Duke laser disc repair. And basically, I pioneered that treatment, the first in the world to do it, the first in the world to publish it. It is a debridement of the annular tear that's full of inflammation where all the pain is coming from. And that's what is causing her pain in her two discs. We call it discogenic pain because the disc is the source of that pain. It's the genesis or source of the pain. Therefore, it's called discogenic. Genic is short for genesis, and discogenic pain is pain that comes from a disc. So what causes that pain? You saw it. It's a tear that gets inflamed, and the body is trying to repair the tear, seal it off, heal it, but it just can't do it. So I come in with the laser and I help it. Seems awfully fast. Is the speed? All right, fine. Maybe it's just loud. All right, if you have questions, we'll take them, type them up. Henry, I know you got a couple.
Yes, we do.
While we're working with the laser, cleaning the tear, go ahead and ask me the questions.
Of course. This first one coming from Brian on YouTube.
Brian? Ryan or Brian?
Brian.
All right, Brian. There's our first piece of herniation. Yes, Brian?
Asking, how would the laser disc repair help pain from modic changes? Looks like this patient may have them.
Yeah, great question, Brian. Thanks for asking. So for those of you who didn't hear the question or know the question, Brian is asking us, everything okay? Yes. He's saying, Dr. Duke, if there are modic changes, spelled M-O-D-I-C, how does this procedure help? Well, Brian, first of all, modic changes don't do anything. They don't cause any symptoms at all. As a matter of fact, anybody that tells you modic changes cause pain is actually not telling you the truth. They don't know what they're talking about. Modic changes are structural changes that are seen on the MRI scan in the end plates, which is the bone next to the disc. And modic changes have been described for many years by pathologists and radiologists, but they're just findings that have really no significance at all. It's kind of like having wrinkles. What do wrinkles contribute to your back pain? Nothing. Wrinkles don't cause back pain, but there's still a structural change. They're seen in elderly, right? The skin, as it gets older and sun damage, it gets wrinkles, but it has nothing to do with back pain. Modic changes have nothing to do with back pain. So this surgery doesn't address modic changes because modic changes have nothing to do with back pain. All right, next question.
This next one is a comment and or seeking advice coming from Raj on YouTube.
Yes, Raj.
Saying, hi, doctor. I wanted to mention when you closed your last surgery that in the UK, the doctors and surgeons willfully lie to their patients about their health problems and they put it down to mental problems.
Oh, yeah.
For me, it was regarding back issues. They lie about the MRI scan results even when sometimes the radiologists get some of the findings right and they say no, they are wrong and nothing is wrong.
Yes, you're correct. You are absolutely correct. It is shameful and sad. Now, I'm going to tell you something. There are a few possible reasons why the doctors tell you there's nothing wrong on the MRI when there actually is. The first reason is the doctor really doesn't understand the significance of the findings on the MRI. They don't understand that the findings are significant and that they are the cause of pain. For example, the question I just took before yours asked me about modic changes. And modic changes have been described by radiologists for years in the end plates around degenerative discs. But modic changes have nothing to do with back pain. Nothing. They're just findings. And just like the radiologists and the doctors in the UK, sometimes they look at the MRI and they say, we don't see anything we can fix, therefore there's nothing really wrong, so just forget about it, right? You don't need to worry about those bulging disc or annular tear. because the doctor doesn't understand the significance of it. Does that make sense? Then the second reason they could be lying is that they're expected to lie to the patient. In other words, most doctors are told that discs are not the cause of back pain. Discs do not cause back pain. Disc injuries do not cause back pain. Herniated discs can only do one thing, and that is pinch a nerve and cause leg pain, weakness, numbness, tingling. So basically sciatic pain or radiculopathy. But they cannot cause back pain. They're wrong. Disc injuries are the cause of back pain, but they just don't know that. So are they telling you this because they're lying because they truly know that there's a problem and they don't want to deal with it? Or are they telling you this that the disc is not the problem because they really don't understand the disc is the problem? They just don't know that because they haven't been taught or trained properly. I don't know the answer. I think both scenarios exist. I think there are doctors that don't know what causes back pain. They're not trained properly. And that's most doctors don't know what causes back pain. It's true. That's worldwide, even in the United States. And the fact that we know at Duke Spine what causes back pain is because we discovered it ourselves. Nobody told us the disc causes back pain. We figured that out through our treatment by treating patients and observing the results of treatment and seeing that we were able to cure their back pain by treating the disc. Therefore, the disc must be the source of back pain. So we use deductive reasoning and logic over the years of treating disc injuries that seemed insignificant to other doctors, yet I recognized them as the source of pain. I treated it with a laser and I eliminated the patient's pain. Therefore, I learned through the process of identifying disc injuries that other doctors would call normal and treating them with the laser endoscopically like I'm doing right now, that I was able to cure back pain. The same thing with neck pain, same thing with thoracic pain. So it's not something that was taught to me, it's something I had to learn. I was taught, like other doctors, that back pain has no basis, that back pain is not curable, that there is no source, that back pain is non-specific. I was taught the same thing. But I challenged that teaching because my patients that had surgery on the discs, had fusions and artificial discs, their back pain went away. So I was really part of a group of surgeons that in the turn of the century, I guess, right? Holy shit, turn of the century? 2000s? Is that accurate, Berndas? Turn of the century? Yeah, but so I was trained in the 90s and early 2000s. So I was part of a first group of spine surgeons that realized the disc was indeed a cause of back pain. Now, doctors in Europe, some doctors in Europe figured that out even before me. They figured out the disc was the cause of back pain. Like they were doing disc replacement surgery, right, where they would do an artificial disc. And they must have recognized the disc as being a source of back pain or neck pain. So I wasn't the first doctor in the world by any means to determine the disc is the source of back or neck pain, but I was part of a small group of doctors that were just starting to recognize that in late 1990s, okay? And so today, the year 2024, we're talking about, 25 years later, more doctors understand the disc is the cause of back pain somehow, but they just don't understand how it causes back pain. They don't understand that there's a tear in the back wall, and that tear is the cause of back pain. I had to figure that part out myself. So even though I wasn't the first doctor to recognize the disc as the source of back pain, I was the first doctor to recognize the tear in the back wall of the disc is the source of back pain. And the first doctor in the world to treat that tear and get rid of back pain. And I've been doing that now for 19 years. We even published our results of the Duke laser disc repair, which is basically treating the tear in the back wall of the disc. So we're the first in the world to do it. I'm the first in the world to recognize The tear is the cause of the back pain and neck pain and thoracic pain. It's the same. Doesn't matter where your disc is, cervical, thoracic, lumbar, which for those of you who don't know what that means, neck, mid-back, and back, low back. It doesn't matter where the disc is. If you tear the back wall, get some herniation in the tear, that can cause pain. And it doesn't happen in everybody, but it happens in the laser surgery on, the one you're watching right now. I hope I answered the question. It was a bit of a roundabout way of answering.
I believe you answered it correctly, though. Got it right. So, no current questions at the moment. So, in the meantime, why don't we show the audience? We showed them how the pain it caused in the facets. Let's show them how we cure that.
I think it's a great idea.
Beautiful.
Facet joint injury is a common cause of chronic back pain. The inflamed facet tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. Inflamed facet joint pain nerves are destroyed. For more details, please visit our website or call us at 1-800-FIX-MY-BACK 349-6922.
That's how close they are. All right, welcome back. We were just talking about my children who are in New Jersey. They go to school next to each other, 20 minutes. One is at Princeton, the other one is at Rutgers. And Dr. Berndes has children as well. Actually, a lot of people in here have children. And yeah, my daughter is actually coming home for a few days to go to a rave concert. Now, in Orlando, yeah. So I need some volunteers to keep an eye on them. Henry? Are you a raver?
Is she going to EDC?
Yes, she's going to the EDC.
I'm going to that as well.
Yeah, I knew it.
Yeah.
So look for her.
That
Report back to me.
copy that. Not a problem. I'll see if I can see if I can find her. It's there's so many people that go to that thing. So
Listen, I love techno music.
yeah, it's
it's
amazing.
I grew up on it. It's my favorite music is techno. Favorite of all music.
It's honestly it's amazing, especially in today's standard of how just the production for music is nowadays. It's really incredible how they execute that music.
Yeah. Arius is actually making music with a sound system. Yeah, he makes
No
techno
kidding.
music.
Really?
Yeah.
Oh, if he's making some music, I would love to hear that. If
Talk to him.
yeah, I'll get in touch with him. That you mentioned that. I want to hear some of that.
All right. Any questions?
Yes, we just got a question coming from Raj once more on YouTube asking, Doctor, facet joint tear. Will the joint remain torn but without a pain as you would cut the nerves, which would cure the pain? Does that not leave instability on the joint?
Great question, Raj. So you are correct. We are not fixing the facet joint. There is no way to fix the facet joint. Once it's damaged for life. But the best we can do, to get rid of that pain from the facet joint is to cut the pain nerves. They are not nerves that you need. As a matter of fact, the only thing those nerves do is carry pain signals to your brain. And patients don't like pain. That's why they come, to get rid of pain. So we want to get rid of those pain signals. And that's the only way to do it, is by cutting the pain nerves. It's called we're in the outer part of the disc, which is the most sensitive part of the disc. So yes, it does not cause instability. As a matter of fact, destroying those pain nerves increases stability. It gets rid of instability. Remember, instability is defined as extreme pain, severe pain, or neurological deficit with normal physiological loads to the spine. So in her case, or in anybody's case, when you destroy the facet nerves, you're getting rid of that severe pain. So you're actually restoring stability to the spine. Pretty good. Yeah. What's that? Oh yeah. We're getting some, not big chunks, but decent sized chunks of herniation out. We're in the most sensitive part of the disc right now. You can see some fat at 12 o'clock. You guys see that at the top of the screen?
Yes, we do.
That fat is called epidural fat. It lives around the nerves and it supplies energy to the nerves. We leave it alone generally. Just about done with this L5-S1. Now remember, the disc is never going to look normal. Our goal here is not to make her discs look normal. Our goal is to get rid of her pain that comes from the disc. Any other questions?
At this moment, no current questions. So in the meantime, why don't we show what is a microdiscectomy and why patients should avoid this at all times?
Yeah, microdiscectomy, for those of you who don't know, is a invasive surgery. It's been around for 100 years. It's not a good surgery. I don't recommend it. It's destructive to the spine. The surgeon has to cut open your bone and ligaments to get down and try to remove the herniation. It's a really, really bad surgery, in my opinion. I don't recommend it, but a lot of surgeons recommend it because they don't know how to do the more advanced, minimally invasive treatments like this, laser surgery. They're not trained to do this surgery, so they do the older surgeries instead.
A large incision is made. Muscles are torn from the spine. Substantial bleeding occurs due to muscle trauma. Normal, healthy bone is removed to access the herniation. Stabilizing ligaments are removed in order to access the herniation. An incomplete portion of the herniation is removed. Dense scar tissue forms. Weakened bones can fracture, leading to instability and pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. And you've seen the video now on the microdiscectomy. We're almost done. This is the hardest disc to fix, L5-S1. And she's not making it easy for me, that's for sure. But we're almost done. Again, we're never going to get 100% of the herniation out. The goal is to get as much out as we can. So I tell people, don't look at your MRI expecting it to be normal. you're not going to see that much difference, but you're going to feel different. And the reason people feel better is because we're actually operating in the one little spot where they need the surgery done, which is the tear. And that's what gets rid of the back pain. Another little piece of herniation, but I think I've gotten everything I can here out. I'll take your questions and we're going to move on to the next disc and treat that next.
This next two questions are coming from, I love this name, Elmo Jackson on YouTube. First question they ask is, so if I'm understanding, the facet joint is permanently damaged. However, by cutting the pain, she'll have no more pain ever. So the facet joint is permanently damaged, so you're going to essentially cut the nerve to permanently remove any nerve and pain sensation?
Yes, that is correct. It's called a rhizotomy. And I did not pioneer the treatment. It's been around for a long time. However, nobody has been able to do it until now, until our technique that I developed. They've tried to do it with needles, but needles don't work. And the needle procedure they've been using is called a radio frequency ablation, RFA. There's 1.1 million RFAs done a year in the United States for back pain. And worldwide, there's probably around 5 million RFAs done worldwide for back pain. However, the pain always comes back because the doctor never actually cuts the nerve. We're the first to do the cutting of the pain nerve. And that's my technique. It's patented, first in the world to do it. And Duke Spine is the only place in the world that can be done. All right, let's see. It's not the skin that's hurting her, trust me. It's the disc. It hasn't. You can push on the skin; it doesn't bother them. It's the stuff deep inside. Like that's the fascia right there. I can numb up the fascia. Fascia is pain sensitive. As we go through it, shot. Looks good, shot. All right, what other questions are there? But so, yes, you're correct. The facet joint, once it's damaged, can never be undamaged. Can never be repaired or healed. There is no way to do it. The only thing you can do is get rid of pain, and there's only two ways to do that. One is our treatment, the Duke plasma rhizotomy, which is the best. Or two, you can fuse this segment. Shot. Man, Jordan, can you clean that up for me?
Next question coming from Elmo once more on YouTube, asking, so if by some freak accident, if she herniated the disc again, she will have no more pain?
No. So, Elmo, you're talking about two different things. The facet joint has its own nerve supply. That's what you watched us cut with the Duke plasma rhizotomy. The disc has its own nerve supply. And we are getting rid of the source of her disc pain by cleaning the tear, where the pain comes from. But the nerves that bring the pain signals from the disc to the brain are still there when we're done. There just is no pain signals anymore because we're getting rid of the source of pain. Whereas with the facet joint, we can't get rid of the source of pain, we can only get rid of the pain signals. The source of pain is inflammation. That arthritis carries on in the facet unless you fuse it. So you have to ask yourself, do you want a fused spine or do you want a normal spine that moves, you just don't have any pain? Most people want to get rid of pain, but they want to keep the movement. And they also don't want a surgery that's invasive. Fusion is always invasive. Hope that clears it up for you. All right, so we got some herniation right here. I'm going to try to pull out some pieces. But generally, with the soft herniations like this, the grabber is not very effective. But we're a bit overexposed. I think we've been overexposed. Yeah, that's better.
Elmo just commented, that makes sense.
Good. My advice, Elmo, spend a little more time on our website. The website is an educational site. It actually has the video animations, but it also has explanations, text that you can read and learn all about back pain, neck pain, what causes it, how to fix it, as well as other treatments that doctors recommend that you should not have done. And it goes through each of those. You should not have it done. Luis, come on. The main reason those other treatments shouldn't be done is they don't work.
We have another question coming from Raj on YouTube.
Yeah. Why is it so?
Asking, what's a hard herniation versus a soft herniation?
Yeah, sure. Soft herniations are like this patient. The nucleus is what's herniated, and nucleus is normally soft, full of water, about 90% water, and it's just like you're seeing, fluffy and soft. Hard is years later after the herniation starts to calcify. It gets calcium in it and it gets hard, like a bone spur. So you get calcification of the herniation, they turn hard, and you get bone spurs around the herniation coming off the bone, the end plates usually, the vertebral end plate. Soft herniations are a bit more difficult to treat. They take more laser energy, more time. They don't vaporize away so easily, whereas harder herniations do. See how this thing has some scar tissue, the white stuff, and it's got the blue, which is the nucleus, but this white stuff right here, it just doesn't, the laser energy goes into it, but it doesn't like vaporize it so easy. It doesn't break it apart so easy. It just punches a hole in the scar tissue, but it doesn't disrupt it enough to release it so that it comes out. So I have to punch many, many holes to get it to come out, which takes more time and effort and energy. Remember, when you're doing surgery, you're always fighting the clock. You're longer your patient's asleep, the more likely they have complications. So you want to get the surgery done efficiently, so the patient doesn't have to be prone, breathing on their belly, cold, bleeding, whatever it is happening in the operation. Come on, Luis. Take it off properly. So we're always racing the clock. And when a disc is like this, where instead of being easy to vaporize, it's very collagenized, then it just adds a lot more time to the surgery. We're getting there. Oh, God. Yeah. Questions?
At this moment, no current questions. So in the meantime, why don't we show the audience of how a laminectomy is performed and why they should be avoided at all costs.
All right. Sounds good. All right, welcome back. Any questions?
Yes, we got two questions. This next one coming from Kenadad on YouTube, asking, can the tube inserted through the annular tear increase the size of the tear, making reherniation more likely?
No, the tube never increases the size of the tear. The tear is always bigger than the tube. The tube is not causing a tear. The tear is already there.
Next question coming from Raj, once more on YouTube, asking, did you enjoy brain surgery as you are a neurosurgeon, right? Is the brain more difficult to operate on?
The brain surgery is definitely harder. You got it? And yes, I'm a neurosurgeon. I've done lots of brain surgery. I did enjoy brain surgery. I do enjoy brain surgery. But here's the thing. There's lots of brain surgeons out there treating those common causes of brain surgery like tumors and aneurysms and AVMs and hydrocephalus and skull-base tumors and all the things that we do brain surgery for. But there are no surgeons out there that are curing back and neck pain. So, as much as I enjoy doing brain surgery, I have to do what I believe I am valued the most to do, which is help people get out of pain. Unfortunately, neurosurgeons, for the most part, are not interested in people's pain. They're really more interested in doing brain surgery and treating those types of conditions. I, on the other hand, enjoy getting people out of pain. I like to end their suffering. So it's my calling. God damn it. Where's the irrigation? Still there? Come on. Come on. Fucking hell. What is this?
At this moment, no current questions.
All right, let's show our audience, since there's really not much interesting right here, let's show them the 30 causes of back pain.
Not a problem. Copy that.
I'm Dr. R. Duke Majan with the Duke Spine Institute, and we're going to discuss 30 causes of chronic back pain. Chronic back pain is back pain that lasts longer than 6 weeks, and there are 30 causes of chronic back pain. The most common cause is going to be a disc injury. Disc injuries such as disc herniations, disc bulges, disc ruptures, degenerative disc disease account for 86% of chronic debilitating back pain, and they are totally fixable with the proper treatment. The best treatment for disc injuries is Duke laser disc repair. Let's take a look at the 5 lumbar discs that can be injured. The most common disc to be injured is L4-5, followed by L5-S1, then L3-4. The L1-2 and L2-3 discs are far less commonly affected. Next, we have facet joints. Facet joints are small joints located behind the discs in the back of the spine. There are 10 facet joints, each paired left and right, L1-2, L2-3, L3-4, L4-5, and L5-S1. The most common facet joints to cause chronic back pain are L4-5, followed by L5-S1, followed by L3-4, in that order. After the facet joints, which account for approximately 10% of chronic back pain, we move on to the sacroiliac joint. The sacroiliac joint accounts with the piriformis muscle for approximately 4% of chronic back pain. The sacroiliac joint is a joint located between the tailbone or sacrum and the iliac bone. There is a left and right sacroiliac joint. In this diagram, you can see the joints turning red, indicating inflammation and pain either in the left or right sacroiliac joint. These sacroiliac joint injuries and pain can be treated most effectively with the Duke plasma rhizotomy of the SI joints offered at Duke Spine or Duke Joint Institute. The fourth most common cause of chronic back pain is a piriformis muscle injury. The piriformis muscle is located in the buttock, and there is a left and a right piriformis muscle. The muscle gets torn, unfortunately, when people bend the wrong way. This usually occurs in patients with orthopedic problems such as hip pain, knee pain, or back pain. By bending improperly, they put the muscle under too much stress and they tear the muscle. The torn piriformis muscle causes severe debilitating pain in the top of the buttock. There is a left and a right piriformis muscle, and this can be treated most effectively with the Duke piriformis muscle release. This is performed percutaneously with a 4mm incision. The sciatic nerve does run through the piriformis muscle, and many patients with piriformis muscle syndrome also have sciatic pain down their legs, with pain, numbness, tingling, and weakness in the leg that's affected on the side of the piriformis muscle. Piriformis muscle can be treated with injections such as steroids, Botox, PRP, or stem cells. However, those injections always wear off and the patients end up coming back with the piriformis muscle pain that reoccurs. The most definitive treatment for permanent relief of piriformis syndrome is a piriformis muscle release. Next, injuries to the bones of the spine, such as the vertebral bodies, with trauma can cause fractures of the vertebral body. Vertebral body fracture is diagnosed with X-rays or CAT scan or MRI, and they're treated with injection of cement into the vertebral body. Looking at the vertebral bodies, the most common to be affected is L1, followed by L2, then L3, L4, and L5. The sacrum can also be fractured. Finally, the coccyx is the last cause of chronic back pain. You can see in the diagram the red coccyx at the bottom. This comes usually from an injury where the patient falls on their bottom, sustains pain at the tailbone, and this can be treated with injections of the coccyx ligament. These are the 30 most common causes of chronic debilitating back pain, the most common being the disc, causing 85% of chronic back pain, followed by the facet joint, causing 10% of the chronic back pain, followed by the piriformis muscle and sacroiliac joint, which cause 4% of chronic back pain, totaling 99% of chronic back pain, which is totally fixable and curable with the right treatment. Thank you. I'm Dr. Duke Machen. Thanks for joining us. Welcome back. So, we are almost done with this right L4-5 herniation, and things are looking pretty good. Not really seeing much left, so we're going to move on to the last disc, which is the left 4-5. We still have the left side to go. Look at all these pieces that came out. Tons. You guys see that?
Yes, we do.
Her disc was pretty badly damaged. A lot worse than I expected based on her imaging. Just no end to the herniations. I think I took 50 pieces of herniation out and we didn't get all of it either. There's still more in there, but we got all that we could get. Remember, we never get 100%, no doctor can. So there's always, it's a matter of how much can you get out, and we've never not gotten enough. Our patient's pain from the disc always goes away, even though we average about 60%. And in my experience, I need a knife. What I found is that patients where you get 50% of the disc herniation out or more, those patients do really well. You get rid of their pain. So you need to clean up 50% of that herniation shot. And anything more than 50 is good. 50%. Shot. Num num. We're working on the last disc, and then we're going to do the rhizotomy right after. Rhizotomy we're going to go straight into. It is a Duke plasma rhizotomy. Left side, correct?
Yes. 4551.
Yeah, she's got some pretty bad facet joint pain and tenderness on the left side at L4-5, L5-S1. The same areas we're doing the disc surgery, except it'll be the facet. Wait.
Yeah.
She's fine.
Yes.
Yeah. You always want to line the dilator up with the disc space, so you go right through the tear. Otherwise, if you're angling wrong, you could end up hitting the vertebral body. Shot? Oh, good. You don't want to hit the vertebral body. Hitting the vertebral body will just cause trauma to the vertebral body. That should be good right there. All right, scope out. Any questions? Happy to answer them.
At this moment, no current questions.
All right, so we're going to do this disc repair, and then we're going to move into a rhizotomy, left 4551. Luis, help me hold this. All right, there it is. Look at that, guys. Wow. Hey, check it out, Henry. This
Yes,
is
sir.
important.
Copy
See
that.
all the pink tissue? That's inflamed annulus. That's where the back pain comes from, guys. I got to clean out the blue stuff, clean up the pink stuff, and then hold this. That's how we make sure that we get rid of her back pain. That's amazing. That was a nice picture, wasn't it?
Indeed it was. I just took a picture.
Well, it's a bit hazy. That's the problem. So, unfortunately, it's not going to be one of our really good pictures, but yeah, you may be surprised.
Yeah, I'll keep it for safekeeping.
The point is, you can see the inflamed annulus. That's where the pain comes from. And by cleaning this out, we're going to get rid of that pain.
We just got another question
Uh-huh.
coming from the classic car nut on YouTube,
Sure.
asking any soft tissues or muscle damage with the DLDR?
Henry, you're dragging your voice. You got to enunciate clearly. I
Apologies on that.
can't hear.
From the classic car nut, asking any soft tissues or muscle damage with the DLDR?
No. The only soft tissue damage is the skin. Nothing else. We're making a cut in the skin. That's soft tissue, 7 millimeters. But there is no other soft tissue damage. Every other spine surgery does a lot of damage to your soft tissues, but not the Duke laser disc repair.
And at this moment, no current questions.
I got about 5 minutes on this disc, and then we'll move to the DPR.
Copy that.
I don't know if it's the laser or the fiber. It just doesn't seem like we're delivering the energy as well. Maybe it's just she's got all this very collagenized tissues, you know? Can't really tell. Just seems like it's barely doing anything, you know? Normally the laser gets rid of this stuff so quick. It's taking forever. Huh?
You want to power up?
I don't know. Do you think that will help?
Okay, we can try it.
I'm almost done. Now, how much juice are you giving it? How many watts?
45 watts.
You can go up to 100.
No.
This fiber will take how much?
Well, you can try 100 if you want, but
But will the fiber take 100?
you can.
I don't want to go to 100.
No. I think it's 53 is what we did before. 53? 53? Like,
Oh, the energy of the pot? You think it could take more?
what is
No.
your-
I mean, we're done.
Not here?
I mean, we're done, yeah. So I wouldn't do it, Luis.
Okay.
Just leave it. Why am I seeing bubbles?
Irrigation fine?
She's moving. She's moving. I'm okay with the movement, but well, we're just going to be doing her facets in a minute, so
We have another question
sure.
coming from, and another question. This first one coming from Raj once more on YouTube,
Uh-huh.
asking, Doctor, that laser looks very powerful, so I'm guessing you need to be be a very experienced surgeon to use this tool, as the laser can go through anything. How many hours take you learn to use it for safety?
Yeah, great question. So it really depends on, for training, it depends on the number of, it's not the number of hours, there's other factors. The type of laser you're using, like the Homium YAG, it's a safer laser. I think you need to be good at using the laser, you need probably at least 20 to 30 surgeries to be able to be good. So, 20 to 30 hours, let's say. Hold it here because it's wanting to twist. That's the problem. It's a good question. I don't know that there's a definitive answer. It's more of just an opinion. It took me about 30 surgeries to get really comfortable with the laser and using it. But that's how surgery is. You're always going to do surgery where you're not 100% comfortable doing it, and you just got to become comfortable. That's what makes a great surgeon. Is they safely learn a skill in time. Nobody learns the skill and then comes and operates on patients. You have to learn the skill on patients. There's no other way to learn the skill. That's how medicine is. That's why you do training. You go to residency and you learn how to operate by operating on live human beings. You just have a supervisor that's there helping you. And that's what I had. I had very good teachers for the most part. And you have to be good at learning. Nobody's just going to force feed you the information. You have to literally be a good student. You have to pay attention. You have to ask the right questions. You got to be aware, of the anatomy. You've got to understand the physiology of the patient and how what you're doing affects the physiology. Did you get the other side or not? No. So there's a lot that goes into it. But you can't become a good surgeon and then operate. You have to become a good surgeon by operating on patients. And there's only so much like laser safety course you can take, right? Can you show it to me? You basically have to learn by operating and paying attention while you're operating. So it's a balance. You can't expose your patient to too much risk, It's not like you can just one day decide, all right, I do GI surgery, I take, colon cancer out, but I want to start doing brain surgery, so I'll just try a brain tumor one day. You can't do it that way. There's a specific protocol for learning how to operate on certain things using certain tools, and I went through that training just like every other neurosurgeon does in the United States. It's 7 years of intensive training using different surgical tools. And I learned how to use the laser when I was a resident. All right. You ready? Shot. It's too high. Shot. That's really good right there. We're doing 4-5-5-1. Everyone agree? Right about here. Right here. Shot. Watch your hands. That's good. So I'm going to make my incision right here. Right there. In the middle of that. Knife. Thank you. Move your hand. Thank you. Incision. We are going to be performing the Duke plasma rhizotomy. Once again, we are no longer treating the disc problem. We're now going and treating the facet problem. Remember, she has two sources to her pain, the disc and the facet. And she has two discs, she has two facets that are causing her pain. So I need to get down, all the way down to where the facet, painful facet is. And I use the X-ray machine to guide me. You can see the tip of that probe is pretty close to where I need to be to. It's got some thick fascia. Shot. I am literally directly over the perfect spot, but I am not in contact with the transverse process because her fascia is amazingly thick. Her dorsal fascia, her lumbar fascia we call it. There we go. I got through it. All right. It's amazing the kind of things that we surgeons laugh at, isn't it? Like thick fascia. I admire her thick fascia. She's moving a little bit. It's not bad for me, but it would be better if she wasn't. Shot. All right, so the tip of that probe is in the perfect spot to destroy the pain nerve to the facet joint. And that's what I'm doing. I'm literally bouncing on top of the TP where it joins the SAP supraarticular process. So that's one down. I could actually feel the pain nerve give. I could feel it. She has some pretty big pain nerves. Shot. The nerves are probably the size of angel hair pasta. Shot. And shot. You must transect them in order for this procedure to work. Transection means cut through. That is the purpose of this procedure. It is a rhizotomy where we cut through the nerve. And I'm the first in the world to do this procedure. It's never been done or published before. And I now have it patented in the United States and also held in Europe. As I say, there's no point in patenting it in China because China doesn't respect patent laws anyway, you know. So in the end, it doesn't even matter. People will come here because we have the most experience doing it and they want the very best treatment. All right, you can see that right there, shot. I am just about done, heading down to the L5 dorsal ramus. I think that's still the transverse process. Shot. It is. I need to get past this guy and get down to the tailbone. Shot. A little bit too lateral. I want to go a little more medial. If you have any questions, this is the time to ask them because we are a minute away from being done.
Yes.
As soon as I get to my target, I'll make that final burn and we'll be done. Shot?
Yes, we have a few questions.
Let me take your questions then.
First one coming from the classic Carnut once more on YouTube, asking, is continued tightness, sort of burning, cramping of lower legs, a common sign of neurogenic claudication?
That's a great question. What we call transient meaning it changes with, it comes and goes. It changes with position. Specifically for neurogenic claudication, it's all related to whether you're standing or sitting, walking, etc. I think that's it right there. Sean, let's see. Nope. Need to be right on the bone. Shot. Got to make sure you're on the bone. If you're not on the bone, then you're not going to be near enough to the pain nerve. Shot.
This next question coming from Kenadad, once more on YouTube, asking, how can you differentiate between annular tear pain and facet pain?
Shot. Great question. Number one, experience, which I have a lot of. Just history, physical. Shot. And there's another thing called probability. But the probability is that it's going to be annular because disc pain is so much more common. All right. Done. Disc pain is 85% of the time the main cause for chronic back pain. So just probability tells us the most likely reason for pain is the disc. It's the annular tear. But the other thing about facet pain is paraxial. What does that mean? Facet pain, if this is the middle of her back, disc pain is generally here in this middle of the back window. Facet pain is off to the side, either left, right, or both. And importantly, facet pain is tender. If you push over the facet that's tender and hurt, it will elicit pain. The patient will say, ow, ow, it's sore, it hurts. For disc pain, if you push, it's never sore. You can't push on the annulus. It's behind the bone. So that's one of the most important physical tools I use is tenderness. The lack of tenderness with annular tears and the presence of tenderness with facet pain. It's almost 100% accurate. Okay? And then being middle versus what we call paraxial, which is to the side of the spine. All right, I hope you enjoyed our surgery. Any more questions?
Yes.
I'll take them and answer them, but we're done. Our patient did really well. Not an easy surgery. Go ahead.
Next question, two more questions. First one coming from Stuart on Facebook asking, I thought if you cut through the nerve, you will have no ability to move that part.
No, that's not correct, Stuart. So the facet nerve that we're cutting through is called the medial branch of the dorsal ramus. It's a sensory nerve. It's not a motor nerve. It has nothing to do with movement. All it does is carry pain signals from the facet joint up to the brain. You want to destroy that nerve. It's a standard idea, standard treatment for chronic pain that nobody's been able to do it before. I'm the first to do it through the technique that I just showed you. And it has nothing to do with movement. It's a sensory nerve only, a pain nerve.
And then lastly, from the classic Carnut once more on YouTube, asking, what's the difference between nerve ablation and rhizotomy?
Well, the rhizotomy is to destroy the pain nerve. Nerve ablation, which is radiofrequency ablation, is one technique to try to do it, but it doesn't work. They don't tell you that when they tell you to get it done. They just tell you get a nerve ablation, but the nerve ablation never works. The only way to ablate the nerve is what I just did. So the typical nerve ablation is done with radiofrequency ablation. It just doesn't work. All right, thanks for joining us, and we'll be back next week. Off from Duke Spine Institute for me and my team. Hope we had an enjoyable day.